Kolegice i kolege, evo nastavljamo drugi dio ovoga simpozija o apoptozi, nakon što su bila ova prva dva uvodna predavanja. I ja bih sada rekla da su u ovom sljedećem dijelu slobodne teme. Dakle, predsjedavatelji docent Šamija, docent Sinčić, moja malenkost. I evo, ja bih molila onda da najavite prvog predavača.
Hvala. Evo, kao dokaz međunarodnosti pa i interdisciplinarnosti ovog simpozija najavit ću doktoricu Lauru Leci Tahiri iz Prištine sa predavanjem apoptoze u stijenci nativne vene u neuspjehu arteriovenskih fistula za hemodijalizu. Izvolite.
Good afternoon. I'm going to present my thesis in English language. It's no problem, I think. I'm presenting myself. I'm a vascular surgeon from University Clinical Center of Kosovo in Pristina. By the time I'm assistant of surgery in Faculty of Medicine in Pristina. First I would like to thank Professor Bulic and Professor Vucic for inviting me in this meeting. It's my pleasure to be here. My thesis today is part of my PhD defense, which I did in the University of Zagreb 3 months ago. And it's my great pleasure here to present that I did my PhD with idea I have got from my mentor, Professor Lovricevic, vascular surgeon in KBC Vinogradska, and Professor Kruslin, whom I would like to thank a lot for the idea. It was my first time to work on apoptosis, and I think it's the first time and for our university in Pristina to do such a study. It's apoptosis in native vein wall in failure of hemodialysis arteriovenous fistula. Just to tell that the samples I have got in Pristina as a vascular surgeon, we do every day these hemodialysis accesses, arteriovenous fistulas, and the other part of the study and the work was done in Department of Pathology, Ludovic Jurak, here in Vinogradska with Professor Kruslin and Professor Majda Vucic. By the time, I would like a lot to thank and my Professor Floriana Bulic Jakus, who is here, and for the consulting her anytime I requested for my thesis and for doing my study in Pristina and in Zagreb. Arteriovenous fistula comes the closest to being an ideal long-term hemodialysis access, and the patient must be instructed in time and protect the vascular access. Native cephalic vein remains the superior dialysis access. It is the number of patients in hemodialysis last 2 decades is going up, so it's the main used access for this hemodialysis is native arteriovenous fistula. Failure of the arteriovenous fistula is a common problem in hemodialysis patients and remains a major cause of morbidity and hospitalization. Puncture of a vein will leave a scar, and when a fistula is created, such scars interfere with harmonious dilation and remodeling, causing turbulent flow and predispose to stenosis. The pathogenesis of early native arteriovenous fistula failure is complex. Predisposing factors include, as we see, a small artery, surgical manipulation, and less than ideal technique, previous punctures, the development of accessory veins that redirect flow away from the primary venous drainage channel, hemodynamic stressors, and the genetic predisposition to vasoconstriction, and normally no intimal hyperplasia after endothelial smooth muscle injury. As we know, apoptosis is defined as an active physiological and genetically controlled process of cell suicide that carries an important function in the development and homeostasis of multicellular organism. Abnormalities in the control of apoptotic cell death contribute to a variety of cardiovascular diseases such as atherosclerosis, aneurysm formation, ischemic cardiomyopathies, infarction, and plaque rupture. Previously, several studies have reported on apoptosis of varicose veins on the lower extremities, then in atherosclerotic plaque rupture and all. And because no research has been done yet on apoptotic cell death in the veins of the upper extremity, this investigation was done. Our hypothesis was that apoptosis correlates positively with previous venipuncture and failure of arteriovenous fistula. It was the general aim of the study to investigate the impact of apoptosis in the native vein wall used for arteriovenous fistulas for hemodialysis on the failure of fistula, and the specific aims were to evaluate apoptosis in the native vein wall of patients who will undergo a surgery for arteriovenous fistula as dialysis access, to compare apoptosis between the veins previously punctured or not, and to assess the number of patients with arteriovenous fistula failure and correlate them with apoptosis. Materials and methods. Vein spacements were obtained from 60 patients with terminal chronic renal disease at the Clinical Vascular Surgery University Clinical Center of Kosovo, who for first time underwent surgery for arteriovenous fistula placement as dialysis access. Normally, we had exclusion criteria, which were in patients in whom arteriovenous fistula did not develop to sustain dialysis or was thrombosed before the first successful cannulation for hemodialysis, as well patients in whom arteriovenous fistula was treated with graft protesis. Group 1, study group, consists of 30 patients in whom the vein which was used for arteriovenous fistula placement had been previously punctured for blood draws or for intravenous lines, irrespective of the purpose of puncture. And group 2 control group normally consists of 30 patients again in whom the vein which was used for arteriovenous fistula placement had not been previously punctured. The history of prior venipuncture was defined with anamnesis by patients or by family member. The patients were prepared for surgery, provided their systolic blood pressure would not be less than 100 millimeters. Both upper extremities were then examined, and the extremity which had an appropriate artery and vein, and preferably the non-dominant extremity, was chosen for the placement of the fistula. The most distal possible site was chosen for fistula placement. All patients had a competent deep vein system without a history of thrombotic episodes. Preoperative evaluation, the veins were sequentially evaluated along the arm for diameter, patency, and depth. Stenosis and thrombosis of the draining or central veins were exclusion criteria. The level of appropriateness of the arteries and vein for creation of fistula were based on the level of atherosclerosis, blood flow, and the presence of thrombosis. Surgical technique. Surgical procedure was performed on the outpatient basis, local anesthesia. The patient was placed in the supine position with the arm to be examined comfortably extended, approximately 60 degrees from the chest. All fistulas were treated as usual manner. At usual manner, radial artery cephalic vein, brachial artery cephalic vein, terminolateral anastomosis end to side with usage of 6-0 or 7-0 polypropylene suture. Cephalic vein was selected to be excised during the procedure. Intraoperatively, before starting the creation of fistula, 1 centimeter long vein segment was excised from its distal part for histological and immunohistochemical analysis. Here we have the pictures how we prepared and how we retrieved the vein. Preparation of artery, radial artery, and cephalic vein. Here we have the vein division, cephalic vein. Again, how we, here, cephalic vein. Retrieving the venous segment, 1 centimeter venous segment. Here is radial artery. And last one is the radiocephalic fistula realized after taking 1 centimeter of the vein. The arteriovenous fistula maturation was observed during the time period of 4-6 weeks, depending on the patient's general condition. Fistula failure was defined as late failure, which is the inability to use the matured fistula after at least 3 months of normal usage. Length of follow-up to the failure was 1 year after first puncture of fistula. Patients were followed up every 3, 6, 9, and 12 months, and failure of arteriovenous fistula was noted. Just to explain here that we have 7 centers for hemodialysis in Kosovo, so we had every 3, 6, 9 months all around Kosovo to check for patient how the fistula is working and to see how the patient are going to do the hemodialysis again. In all patients, hemodialysis was performed in standard fashion, as we know, 3 times per week for 4 hours. Tissue preparation, all vein specimens were divided into 2 portions along longitudinal axis. The specimens collected were fixed in 4% formaldehyde for 24 hours and embodied in paraffin for conventional histology and immunohistochemistry. Histology and immunohistochemical analyses were made in Ljudevit Jurak Department of Pathology in University Hospital Center, Sisters of Mercy in Zagreb. Histology, specimens were stained with hematoxylin and dosing for routine histological evaluation. Results were evaluated by 2 independent investigators who were blinded to the patient's clinical findings. All vein specimens were stained with Mallory trihome, Gomoris, and von Gison's histochemical staining to assess the pathological changes in the amount of collagen connective fibers and to differentiate between collagen and smooth muscle fibers, as well as the elastin network. For the purposes of immunohistochemical analysis, the antibody panel most commonly used in the literature was selected as follows: P53 mouse monoclonal antibody, BCL2 mouse monoclonal antibody, Caspas3 mouse clonal antibody, Darko production all, Bugs rabbit polyclonal antibody. Streptavidin biotin peroxidase method was performed according to the instruction from manufacturer for visualization of the antigen-antibody reaction. Biotin conjugated secondary antibody was applied in 1 to 200 dilution for 1 hour at room temperature. Then a 30 minutes incubation is strapped AUB complex for color development. 3.3 diaminobenzoate tetrahydrochloride and hematoxylin as a contrast stain was used. Qualitative and quantitative evaluation of immunohistochemical staining was performed with computer software, as described by Phyllis et al. In 2011. The expression of proteins was evaluated according to a semi-quantitative assessment of positive cells according to criteria of fitness. Scoring was performed as follows: no staining, minimal staining 1 to 3% positive cells, moderate staining more than 3 to 50% positive cells, and maximal staining more than 50 to 100% positive cells. Positive cells, cytoplasmic and nuclear staining for the exomite antibodies in the intima, media, and adventitia were counted at 400 magnification and quantified in 10 random fields per section. As positive control for BCL2, Caspas3, and Bugs, tonsillar tissue used, and for P53, breast tissue. Negative control was obtained by omitting primary antibody. Statistical analysis, chi-square test or Fisher-Freeman-Halton test were used to test the differences in proportion of qualitative variables between groups. Normality of quantitative variable distribution was tested by Kolmogorov-Smirnov test. Mann-Whitney-U test was used for testing the difference between quantitative variables, which did not follow normal distribution. The level of P less than 0.05 was considered as the cut-off value for significance. Ethical approval for the study was obtained from all University in Pristina and University here in Zagreb. Identity of patients remained confidential and protected. Results. According to preoperative physical examination as well as non-invasive imaging findings, which was ultrasound, which was done from vascular surgeons, not from radiologists, because we had to exactly know the diameter of vein, the diameter of artery, and we found out 60 patients on maintenance hemodialysis with an arteriovenous fistula at vascular access, which were appropriate candidates for this study. Here we have the characteristics of patients, number 60. We see the median age for study group 1 was 63.50, for the second group, for group 2 was 63. So as we see, the patients who were not on dialysis when we realized arteriovenous fistula, meaning that the fistula was done for preventive, of next time to use. Then for dialysis, and after 2-3 months they were on dialysis. So we follow them 1 year again. And here we have the patients who were on central venous catheter, meaning that the time where we realized arteriovenous fistula, the patients were on dialysis, maybe for urgent hemodialysis or for dialysis because they came too late in hospital and we need them to put immediately in hemodialysis. As we see, we don't have no significant differences between groups according to these characteristics. Intraoperatively, we see that on non-dominant extremity, we had 24 and 28 on second group. Again, we don't have significant differences between groups according to this choice of site of access site, type of fistula realized, condition of artery and condition of vein. We have here Fisher's exact test done, and histological and immunohistochemical analysis, routine high staining showed histological appearance of the punctured and non-punctured vein specimens. On high staining, there were signs of apoptosis in the form of pycnotic bodies who were located outside of cells. We have here the control vein, the intima endothelium, the media here with 2 stars, and we have the magnification here. The control vein, the arrow points to the intima of the vein. Here is the media with 40 magnification on high. The punctured vein again. We have intima, media here. In punctured veins, Mallory and Gomory's histochemical staining demonstrated a loss of their elongated morphology and slightly increased collagen matrix. Von Gison's elastic staining showed degradation of elastic fibers compared with non-punctured veins. Here we have the control vein, Mallory, Gomory, and Gisson staining. And here we have the punctured vein, again, Mallory, Gomory's, and von Gisson staining, how they look like. Semi-quantitative analysis of markers expression in study group was like this. We have here the minimal and moderate staining. We can see for P53, we had only minimal and moderate, we had no staining and minimal staining. For BCL2, CASPAS, 3, and BAX, we can we see that for CASPAS 3, we have minimal, moderate, and maximal staining. The same is for BAX. And we found out that for BCL2, we have only minimal and small number of moderate staining. Here we have on diagram how we present them. We have here BCL2 on the no staining and minimal staining, and we found out that on moderate and maximal staining on study group, we do not have BCL2. So meaning that BCL2 is an anti-apoptotic marker, P53, we see that we have only on no staining and minimal staining. The positive cytoplasmic immunohistochemical staining of plaques we see in the media and intima of the study group on the punctured veins. We find we have magnification of 200. It points on arrow points on intima, and the media is here and adventitial. So we see the positive cytoplasmic staining. Here we have the immunohistochemical staining for Cas-Pas3 in the media and intima of the punctured vein. Normally we have cytoplasmic staining again. Positive nuclear staining for P53. It points on nuclear staining here on punctured veins. And the same analysis for P53, BCL2, and Cas-Pas3 and Bax we have for control group. We found out that P53 is exactly the same number on no staining and minimal staining. BCL2 we have a big number on maximal and moderate and minimal staining. And we found that Cas-Pas3 and Bax is on no staining and only on minimal staining. Here we have only for BCL2. We don't have for Cas-Pas and for Bax staining or moderate and maximal staining. For P53 is exactly the same with the study group. Nuclear immunohistochemical positivity for BCL2 in the media of the control vein. Normally the arrow points to the positive reaction here, visible as a dark staining in nucleus. The same positive cytoplasmic staining for Cas-Pas3, intima and media here. Positive staining for Cas-Pas3 in the magnification of 400. We see the positive cytoplasmic staining here in the media. We compared the apoptotic and anti-apoptotic markers expression between the study group and control group, and we found that we had here for P53 no significant differences between groups, and for BCL2 and for Cas-Pas3 and Bax we have significant increased exactly for the group with previously punctured veins, significantly increased Cas-Pas3 with P less than 0.001 with Fisher's exact test, and Bax expression P 0.002 Fisher's exact test, and significantly decreased BCL2 expression for P less than 0.001 compared with the control group. The two groups showed no significant differences in P53, high square 0.071. The expression of P53 comparing between study group and control group. The expression of BCL2, this red one is control group. Expression of Cas-Pas3, the study group here, and expression of Bax. Fistula failure was significantly more common in the study group, 26.7% versus 6.7%, high square 4.32, and P 0.038. In conclusion, no significant differences were found between the study group and control group in age, sex, and comorbidities before arteriovenous fistula placement. Previously punctured native veins used for hemodialysis access exhibit increased apoptotic activity by means of increased Cas-Pas3 and Bax compared with non-punctured veins. Significant decrease of BCL2 as an anti-apoptotic marker was found in the study group compared with the control group. The positive apoptotic findings were not related to patients' age, sex, or comorbidities. Patients with increased vein wall apoptosis showed increased fistula failure, suggesting an association between apoptosis and fistula failure. The association we found between apoptosis and fistula failure indicates the role that apoptosis plays in the function of fistula. I deeply thank to all who have helped me in my investigations.
Thank you very much for your interesting lecture that shows potential relevance of apoptosis research for solving some very practical problems in clinical medicine. Maybe we can have more general closing discussion after all the presentations, but right now, if you have some pertinent question relating to presented results, you can ask Dr. Leci Tahiri.
May I to ask you, how do you explain the positive reaction only in cytoplasm for caspase-3?
Sorry?
How do you explain the staining of the caspase-3 only in the cytoplasm?
The caspase-3 of
Yes,
the results
yes,
of caspase.
yes.
Of course, for deciding to do this research, we have looked at a lot of researches before on the veins and arteries. And we haven't found any, as I said, we haven't found any research on the veins of the upper extremities, because in the lower extremities, we know hemodynamically the veins, the pressure is higher in the veins of the lower extremities. So as we searched on the literature, we found the caspase-3 is the apoptotic marker. So we decided to search. The hypothesis was just to search for, because we haven't found any study before. So we then, after the 3 years of work, because 5 years ago we decided to do this research, we have found that the caspase-3, as in other researches for apoptosis in the veins and arteries, is as a marker for apoptosis.
Yes, okay, but the caspase-3 is positive in nuclear, also have nuclear positivity. And how do you explain this only cytoplasmic staining in your material?
It's a pathologic part. I really maybe to ask Professor Kruslin for these differences, big differences, because from my side I cannot exactly explain why only nuclear or only cytoplasmic. Because it was first research and for the professor and for us, so.
You should ask this to Professor Vucic for actually analyze.
She's not here, so.
Okay, okay, thank you.
Thank you. Thank you very much.
Are there some other questions? Okay, thank you again.
Thank you very much.